Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. Love it. Okay, awesome. Let's get started. All right. Okay. We're going to do something educational again today, or hopefully educational. I feel like we have some decent insight on these topics.
Well, every episode is educational.
It is. That's true. I shouldn't preface it with that. Yes, but this is going to be more ortho topic related. Some pearls for the ortho providers.
Yes, we're going to dive into the shoulder today. So I live and breathe in the shoulder. I would say 80% of my week. Hannah, what are you, being upper extremity as well? How much do you see shoulder?
Shoulder is probably more like 30% of my week, I would say. It's climbing up there. Our practice is becoming more and more shoulder related, which I like. Yeah. And I know why. And we'll talk about that.
So I think shoulder patients, when we see them in orthopedics, whether that's a scheduled patient or like an injury express or an urgent care patient, I think shoulders for a provider, and again, new versus experienced, I think shoulders are hard because, like a knee goes front and back, right? A shoulder, there's so many planes of mobility. So even knowing what normal is to then distinguish what abnormal is, I think is kind of hard. So when I started, I remember working with a shoulder surgeon, and just the anatomy arthroscopically was kind of hard to wrap my head around. And once I got it, like on a right shoulder, then we do a left, and I'm like, oh God,
I don't start from square one.
Yeah. So, all right, let's talk shoulder. So, shoulder pain, when we see patients that have shoulder pain, I guess I didn't want to start this way, but let's start with a pet peeve of mine.
Okay, yeah. Let's start with the pitfalls.
Okay, so patients that have shoulder pain that is orthopedically shoulder pain is usually localized to the outside of the upper arm.
Yeah.
Okay, so someone who comes in that has pain in the top of their shoulder, not their AC joint, but like trap and then shoulder blade. Yes, that is my shoulder. If you ask me where my shoulder is, I would probably point there, but that is not orthopedically their shoulder.
Right. Yeah. Step one to the shoulder eval is differentiating true shoulder pathology versus cervical spine pathology, thoracic spine, or scapulothoracic.
Yes. Yeah. So why we care is because when we work in a surgical shoulder field, we're not operating on scapulas. We're not operating on upper traps. At least not yet. We're talking about doing upper trap transfers for a surgery. But anyway.
What?
Yeah,
oh my
we'll
gosh.
talk about that
that's
later.
Different.
But anyway, so shoulder pain, let's say the patient comes in and this is equally male and female. I would say as the decades go on, like 40s, 50s, 60s, 70s, you'll see that bell curve really spike in the 50s, 60s. But patient comes in, their arm hurts. We generally take x-rays of the shoulder. And it's funny because I don't know if you've had this experience. Patients will say like, oh, you're x-raying my shoulder. Can you get, and they'll point to like their bicep or something. Can you get that? Because that's generally where their pain presents. But anyway, so we get x-rays and talk through a shoulder x-ray.
Okay. So typically, and everybody's different with like what their preferred views they get are. I always get 4 views, AP, Grashy, Scap Y, and an axillary. Are those the same that?
Yep.
So things that I am looking for initially, well, first is this traumatic or atraumatic shoulder pain. Traumatic shoulder pain, obviously we're looking for proximal humerus fractures. We're looking for glenohumeral dislocations, clavicle fractures. And then there are some things that can cue you into certain soft tissue injuries. So we can get into that some too. And then atraumatic shoulder pain, obviously my radar is not high looking for fractures, things like that. So I'm more cued into those like subtle soft tissue, the things that can indicate soft tissue problems. So speaking specifically about like the rotator cuff interval and the space between the acromion and the humeral head. Looking at those things, obviously joint wear, looking for arthritis.
Yeah. So I think really important to look at if you're someone who looks at x-rays all the time and shoulders scare you or they're kind of intimidating. So glenohumeral joint space, like what does the space look like? Are there any bone spurs on the humeral head? And then, like you said, that rotator cuff interval space, so the distance between the acromion and the humeral head. Humeral head elevation, if you see that on x-ray, that's a little silent indicator of a long-standing rotator cuff dysfunction. I do every single time I look at that lateral Y, you're looking at the acromion morphology. So the type 1, type 2, type 3 acromion to see if there's any type of impingement which will predispose to rotator cuff issues. AC joint, looking to see if there's any degenerative changes or bone spurring specifically inferior at the in that, subacromial space. So x-rays, super important. For rotator cuff, I would say non-diagnostic, but they're not useless, right? So super important. When you see a patient for a physical exam for a shoulder, just starting with the basics, right? So looking at their shoulder, patients that come in that hurt themselves or that tear their rotator cuff generally don't bruise. And I remember when I first started out, I was like, but why? Like,
yeah. Shouldn't I see something?
I should see something, right? But you're generally not going to see that. Proximal biceps ruptures, you're generally going to see something, whether that's a defect or bruising. But when you look at someone, unless it's a shoulder dislocation, they're not really going to, or proximal biceps rupture, they're not going to look crazy abnormal. Yeah. Passive range of motion, active range of motion, strength testing, special testing. And if you're, really good at your shoulder physical examination, that should kind of gear you toward what you think that patient has. Hannah, what's your verbiage when you talk to patients about rotator cuff disease? Like I don't like to say
the
disease.
Spectrum of rotator cuff issues. So I do explain that it lives on a spectrum, and saying that you have a rotator cuff problem could mean anything from there's inflammation or maybe some mild fraying at the cuff insertion, all the way to partial tearing and leading up to eventual complete tearing of it. So you could live anywhere on that spectrum. So like the typical codes or diagnosis things that we put in here, rotator cuff syndrome, rotator cuff impingement, all those sorts of things is somewhere on that spectrum of, is this just inflamed and irritated? Do you have partial tearing, or is this like a surgical level of tearing?
Yeah. And I think what's really interesting, what I like about the rotator cuff and just seeing these patients is if you describe the spectrum of disease, right, and you start at the left side of the spectrum, which is, let's say, a tendonitis or an impingement.
Yeah.
Majority, and again, I'll say it like that because you will see people that are not this, but majority have pain positionally, maybe some pain at nighttime, but generally no weakness, right?
Yeah.
And they respond very well to minimal things. Let's say that is ongoing. Let's say it's not. Let's say a patient comes in and they're a little bit more symptomatic. So they've lost some range of motion. They have pain with certain movements. They have pain at nighttime and they have some weakness. That makes me feel like they've kind of climbed down that spectrum. And then, add symptoms on top of that. Let's say unrelenting night pain, cannot lift their arm. Now they're further down that spectrum to tearing. And then massive tears are those that have either been long-standing or they're, second to a fall or something like that. But what I love about it is that you'll see patients that have, let's say, impingement, so on the far left end of the spectrum, and are dying.
Yeah.
Like, it's like the worst thing
I was
in the
actually
world.
just thinking about that as you were talking. Like, yes, what you're describing, like, is the typical. But, like, so often we'll see the atypical where I'm like 100% convinced. I'm like, ooh, I'm going to get an MRI initially because you have a massive cuff tear. And it comes back and it's like, tendinosis. And I'm like, oh my God.
Yeah.
Okay,
So
good news.
Yeah. No, it's funny because I think your clinical exam and the history taking and all of the important things play a role here, right? So you'll see those patients that have essentially minimal pathology and their exam is like out of this world.
Yeah.
And then you'll see the 50-year-old mechanic that's had shoulder pain for like 2 weeks, no fall, no nothing. And you go to examine him, you're like, you haven't had a rotator cuff for 10 years.
Yeah.
Like that was torn 10 years ago. I saw a guy like that this week, actually. Yeah.
And it's the demographic you're describing.
I know. And they can lift their arm.
Yeah,
like,
I know. You're like,
head.
oh, wow. Like great compensatory motion.
Especially when I have a student. I was like, let's go in and look at this guy that has like a massive tear. He can't lift his arm. And then he literally touches the ceiling. And I'm like, God damn it.
Yeah. Like, huh. What do we do here?
Right. So, let's talk then about, again, conservative treatment, blah, blah, blah. We can talk about that another time. Let's talk about the stuff
we want to talk about the good stuff. So, I mean, we'll briefly touch on it. Okay. Conservative treatment, steroid injections, you're typically doing that where on your spectrum, like tendinosis, impingement, bursitis.
Those that don't have weakness get a steroid injection. I feel like that's a win-win.
Yeah.
So anti-inflammatories, of course, first, but not long-term. But steroid injections for those that I'm not thinking have any type of surgical problem yet, I will do inject. Or, sorry, caveat, those that do have a problem but will not entertain.
They're not ready for it.
They're not ready to hear it.
Yeah.
They're not ready to get a test for it. And I'll inject those ones too.
Yeah.
But physical therapy, and I hate when the patient's like, oh, I don't really believe in therapy. Physical therapy with the right therapist for a shoulder problem is a game changer.
It is. And I explain it to them because like it can be hard to convince people to go to therapy for anything.
Yes.
But for this specifically, I explain like, okay, maybe you go to the gym already or you use your arm at work so you don't feel like you need the extra exercise. That's in air quotes.
Yeah.
But we are trying to train a very specific group of muscles. And I explained to them the concept of what the rotator cuff does, right? So the rotator cuff's job is to depress the humeral head when you're elevating your shoulder. And in the setting of rotator cuff dysfunction or rotator cuff weakness, that is kind of the snowball effect of impingement. So the rotator cuff is weak. Now it's allowing itself to get more impinged. And without properly training it in therapy, that cycle will then continue. So I can give you an injection, it can feel better, but without therapy to retrain things, then the cycle will continue and potentially worsen.
I think the key is understanding it and explaining it to the patient in a way that they'll understand. So when you start, saying the word supraspinatus, subscapularis, infraspinatus, like we're done. We've lost the patient. Their hand's like on the door, right? But when you talk about how it is important to stabilize your shoulder, and if not this, then that, right? So if you don't have that, your deltoid does all the work. If you don't have that, your mobility is less. If you don't have that, the ball rises up in the socket and causes bigger problems. So I think I do a good job. Do you do a good job explaining?
I feel like it, for the most part. And
I do like saying supraspinatus, though.
Yeah.
I like to call it the workhorse of the rotator cuff.
The workhorse.
I do. I say that a lot.
How many times a day does Beth call it? The supraspinatus, the workhorse.
Many times. So many times.
But yeah, I feel like I do the same injection-wise, right? Obviously, it's not like surgical pathology. And then if it is, we have the frank conversation that this is not curative for you and it's probably going to get worse. But hey, we can do it. And I can temporize you right now, and we can address this problem at a later time.
Yeah,
hopefully.
But also, like sometimes steroid injection helps the rehab effort.
Yeah.
Right. So if you have someone who comes in, and a very typical story is it's been hurting for 3 to 4 months, but recently I can't sleep. Like that's the game changer.
Yeah.
Like I would not have come in, but now I can't sleep.
Yeah.
Right. So now they're looking for help with that. So steroid injection to decrease pain and promote sleep, and then therapy to strengthen in the window where they're not having pain. But you're right. I will very clearly tell them if I don't think that it's just like, a minimal thing, this may help your pain, to see if therapy is going to be successful. So when will you get an MRI?
So my typical algorithm, so traumatic issue with like the right exam findings where I appreciate a lot of weakness, I'll go ahead and get it right off the bat. Or, the patient that's been having this issue for 10 years and then they come in and see me and they've got
profound
massive weakness. Yeah. And I'm like, okay, your cuff's been torn for a long time. We're going to go ahead and get it. Otherwise, it's typically someone who I've been doing all the conservative things for, and maybe they've had an injection. It worked really well for a couple months, and then they did a second and it worked less well. And we've just had this like downward effect of things. Or, honestly, like sometimes the people who don't get better like I would expect them to with the initial injection, like I'm not suspecting a massive tear. I would expect them to get better after my injection and after therapy, and that just doesn't happen. Yeah. I'm like, all right.
Yeah.
Yeah.
Okay. So we get the MRI, you're seeing the patient back. I think that's a very powerful visit, especially when you can look at the images with the patient and talk them through what the cuff looks like, right? So here, look, this is tendinosis. This is a partial tear. This is a full thickness tear. Like this is why you hurt. And no matter how bad it is or not, I think patients are like, oh my God, yes, I'm like, that's it.
They get to
like,
see
I'm not
the thing.
crazy.
Yeah.
And I think at that visit, because again, you'll see patients on that spectrum, and full thickness tears do not heal. That's not an opinion. That's a fact,
Yeah.
right? But not all full thickness tears require surgery. And that is the whole conversation. So
Yeah.
we'll, I guess, put a pin in that. But even the partial thickness tears that you see and you're like, okay, chances are you're not going to require surgery. But if you lead that discussion with, oh, this will not require surgery. Well, it might, like, if you don't get better with all the other things, because everybody's so different as far as what their job is and how long they've had symptoms and what they've tried so far. So it's very important not to marry like you will or you won't.
Yeah. Do you feel like
you're the idiot, right?
Patients have like a hard time swallowing that like up in the air concept of like, well, here's what we can try and it may go this way, but it could go another way. And like, I don't have a definitive like 100% this is the answer right now for you?
I like to put it in the like low grade tears, less than 25%. Generally, these do not require surgery.
Mm-hmm.
So I will give you the benefit of the doubt and try therapy, but everyone's different, right? So, and then those that are the partial thickness 50% tears, I will tell them, hey, this could go either way. And then you will know when you say that, because some people are like, oh my God, I don't want surgery. Okay, well, it's going to go that way then.
Yeah.
Or some patients
You're
are
motivated.
Or some patients will be like, I've had this pain for 2 years and I'm done.
Yeah.
So I will, for that same MRI for patient A, patient B, like I may recommend surgery, may not, just depending on what all the other factors are. But let's get down to the...
Well, quick caveat before that.
Okay. Let's not
do you PRP?
Yeah.
The cuff?
Yeah.
50% or less, 20% or less?
Yeah, 50% or less. 25%ers just did 2 last week. And so far, so good.
Nice. How long does it take for them to see results usually?
How long does it take for them to hate that? 2 days.
Immediately.
Oh, okay. Immediately.
Yeah.
The PRP in the shoulder, in the bursa, not so bad. In the bursa, if you really want to get it in the tendon, pretty bad. So I will tell them 2 weeks, you're going to regret doing this. Give it 2 more weeks after that to reach like a new baseline. So I'll see them back about 4 weeks later.
Okay. Yeah.
I will tell them it's kind of painful and there's no real, like, do you know? I don't know. And I will play with it. Like I'll do 1 and then maybe I'll do a second one.
Yeah.
But I won't do more than 2.
Yeah.
Yeah. I won't do more than 2.
Yeah. I do. I mean, I have never done PRP for a rotator cuff because we'll send those to you typically.
Yeah. Okay.
Do it a lot for tennis elbow, but separate story for another day in maybe a couple weeks.
But let's talk about what like the hard, challenging part about rotator cuff surgery is. And again, not for the patient because that is hard and challenging. I'm talking about for me. No, just kidding. But okay, so the factors that go into how a patient will do with the surgery are pretty robust. Okay. So I will tell them at our preoperative visit, because they're like, how successful will this be? Well, loaded question, right? The size of the tear is a variable. The age of the patient, the tendon quality, the surgical technique, and how compliant they are with therapy. Those are all huge, and not one is better than the other, to be totally honest. So if I have a patient that has a small tear, that has not had symptoms for a while, that has not had a lot of injections, that will not go back to overhead activity, they'll do okay. Ooh, wait, but they're diabetic? They may not do okay, right? Or I'll have a 50-year-old that's had a tear forever and needs to go back to work in 2 months, hears me tell him 6, really interprets that as 4, like he's not going to do well. Or the one that says, I generally don't need therapy. My body heals well on its own. Not going to do well.
Yeah.
You know what I mean?
Yeah.
So there's so many things. So
buy in.
Yeah. Let me put it in perspective. So the overall re-tear rate, okay, for small to medium tears, we're talking less than 3 centimeters, which I guess would be small, is about 20%. It's pretty damn high.
Yeah.
Really high. Large tears, which are 3 to 5 centimeters, are about 25%. Massive tears are anywhere from 50 to 90%.
Oh my God.
Oh my God.
That's a lot.
It's a lot. So chronic massive tear. So the ones that don't know they're torn but have been torn for a long time, the research will show that's anywhere from 36 to 57%. But that's like a lot. Yeah. And that's if you do everything right. That's not, the smoker. That's not the diabetic. That's not the one that went back to work too soon. Like there's so many variables that can make that more or less, generally more. Than less. So, what I really wanted to talk about was we do the surgery. Okay. And typically it's an outpatient surgery. It's done arthroscopically. whether that is a small, large, massive tear.
Mm-hmm.
Patients are in a sling postoperatively anywhere from 4 to 6 weeks. They're in physical therapy anywhere from 3 to 9 months.
That's a long time.
It's a long time.
Yeah.
So you're making a commitment. And I will tell them when we see them pre-operatively or when we're at MRI stage, like, if we're going to fix this thing, this is now going to be the next 3 to 6 months that you're going to have to commit to this, which they hear it. And then they're like, okay. But then like when it gets down to it, it's like, so let's say we have the patient that does everything right and we see them back monthly. And when they should be doing overhead, they can't. It still hurts. They still can't sleep at night. I'm starting to think like,
did something happen?
Well, okay. Did something happen that you didn't tell me? And 10% of the time, yes.
Mm-hmm.
They'll be like, oh, well, like 2 weeks after surgery, like I reached for something and I
walked my
didn't
dog
want to
and
tell you because I knew you'd yell at me. Right. But yeah, I start to think like maybe it's not healing correctly. And rotator cuff failure, if you get an MRI scan, like you want it to show a tear. You want it to be like, oh my God, there's the gap.
Mm-hmm.
You have retorn, but it's not that clear cut. Sometimes it's like super tendinopathic. Sometimes there's just, it's super thick, like it's super, well, it's tendinopathic, but sometimes it's super thin. Sometimes it's super thick. Sometimes it kind of looks torn, but it also kind of looks like you just repaired it.
Yeah.
So like you have to pair how they're progressing with what the MRI scan shows to decide to
go back in.
Yeah. Yeah. So going back in to do a revision, you're taking out more tissue. They're less likely to have a successful recovery. So you have to have that conversation. I think, and again, tag my work to your work. Hannah does surgeries that are reverse total shoulder replacements.
Yeah.
And,
well, not me myself, but
I mean, like she's
I'm
there.
physically present. But yeah.
Like, participate.
Yeah.
So
I'm an active participant.
So we don't. The practice I work in, we do rotator cuff repair, small, medium, large, massive. And when those rotator cuff tears fail, there's a couple paths to go down. Okay.
Yeah.
So one is recognition of failure, not of the patient.
The first step is acceptance.
No. So seriously. So if we don't have a desired result, there are a couple different paths. One, do we acknowledge it's not working, like it's torn or it's just not going to ever get back to where you were? If we acknowledge and we accept, we leave it alone.
Mm-hmm.
If it's retorn and you're not happy, then we can talk about a revision, but the risk is you may go on to that may
the
fail.
Same thing. Yeah.
Or you'll talk to the patient where it has retorn or it's failed, and the next step is a reverse shoulder replacement.
Yeah.
And when I say those words, I actually have one patient that the practice did a couple of years ago that I always pull up. I'm like, let me show you what that looks like. And whoa.
Yeah. Crazy.
So, Hannah, explain where a reverse shoulder replacement comes in and why that's an acceptable alternative.
Okay. So a reverse total shoulder. So shoulder arthroplasty, right? You have two types: anatomic, where it's just for primary arthritis, glenohumeral arthritis, but we're talking about a reverse. So we're reversing the anatomy of the ball and socket. So we are basically taking off the humeral head, and that is getting replaced with a stem and cup implant, and then the glenoid portion, or the glenoid portion is getting a sphere implant on it. So we are taking your ball and socket and making it socket and ball.
Reversing the orientation.
Yes, we are. And so that basically mitigates the need for your rotator cuff to be intact and functioning, because changing that anatomy, you are changing the center of rotation, essentially.
So it's negating the need for the
and
depression.
You're also changing the tension on the deltoid muscle, and lengthening things so that you are relying on your deltoid muscle to be what is primarily functioning for shoulder abduction. So you don't need an intact cuff when we do a reverse. So these are great for patients with glenohumeral arthritis with an insufficient cuff, or just an insufficient cuff, chronic cuff tears, or the re-tear patient, as we were discussing.
Yeah, the re-tear patient. Yeah. So what do you think is the prevalence? And again, I'm chat GPTing this. What's the prevalence of rotator cuff arthroplasty versus reverse? And I'm only asking because one, I don't do it, or I don't participate in it. Excuse me, I don't do any of these primarily.
The prevalence of what? Of
anatomical arthroplasty versus reverse. Because in
like
the
80-20,
common,
I feel like. Yeah. But in our practice, 100-0.
Well, that's what I'm saying. So in like common non-academic literature, just literally hearsay, it's more reverse.
It is always more reverse. So
because if you do an anatomic and then you tear your rotator cuff, SOL.
Yeah, so that's a common conversation that I have with people. I just had that conversation with a lady today who's primary glenohumeral arthritis. Like her rotator cuff interval looks okay. I got a CT scan for planning because we get that, not an MRI. So I can't really, it's not great for evaluating the cuff, but her cuff looks like it's okay and it's strength-wise it's functioning. So you could be an anatomic. But if at some point that cuff fails, or if you get in there and it just really doesn't look great, you'll want to do a reverse. Yeah. Overall the incidence of reverse is higher. And a doc we were talking to a couple of days ago, he was giving us some stats on the incidence over the past couple of years. It's shifted dramatically more towards reverse even recently. In our practice specifically, 100%. We just have not had the right patient yet for an anatomic. People, especially the age range we typically get, just don't like the idea of potentially having to go back and do something different. They want whatever the end game is. Yeah.
So it looks
more
like
more predictable result.
Yeah, I'm just looking at some data. So it looks like in 23 and 24, if you're asking, AAOS does an annual report in 23, and 50% were reverse and 40% were anatomic. I don't know what the other 10% are. But if you ask single high volume institutions between 2017 and 2023, reverse total shoulders went from 77 to 83% versus anatomics declined from 19 to 17. I feel like reverse is more common just because, again, the age population, the rotator cuff at 50 is not pristine. Yeah. They may not know it, but it's not pristine.
Yeah, and at some point it probably is going to wear down a little bit. Yeah. So we have the conversation of reverse total shoulder when a patient comes in who, like Beth was describing, maybe they have had a rotator cuff repair and it's failed and we need to move on to a reverse, or somebody with a chronic rotator cuff tear, right, who it's just not in that repairable state. Maybe it's been torn for 5 years and the tendon is all fatty tissue now, or just so retracted that it can't be repaired. They're a good candidate for a reverse.
So I say that though, and I feel like I'll say okay, we could do a reverse, or unfortunately I'll have the conversation of your rotator cuff is so badly retorn, it's so retracted, there's so much humeral head elevation, the best surgery for you is a reverse. And they look at me like I just gave them a death sentence. Why do you think that is?
I don't know, but it shouldn't be. I feel like people think that it's dramatic, but I feel like I do a pretty good job of undramaticizing it. Is that a word?
Yeah.
It's actually and we're talking and I think the youngest patient we've done this on she was in her 40s. Just massive. Yeah, it is. But I mean, still good outcome. Yeah. I mean, if you saw what we were starting with, but I think the patient population typically that we're doing this on, they're getting a great outcome with this.
Well, I'll tell you, if I compare someone who just went through 6 to 9 months of rotator cuff repair, and then again, we walk that line down of, are you happy? I don't know. Let me give it a couple more months. Okay. Well, I'm concerned about your rotator cuff healing because you can't lift your arm over your head and it's been 6 months. Yeah. No, I'll give it longer. And then we walk down that line and then we get the MRI and then, it's torn. Doing the reverse, they're done with everything in a shorter period of time.
It is
than a rotator cuff. Yeah. So when I inject that in the conversation, they're like, oh, that doesn't sound so bad.
Yeah. Yeah. So, I mean, the conversation that I'm having with these patients, say we're seeing the person with the irreparable second time tear, sent to us because there's really no repair option available. So basically, I explained to them, what are options we have for you at this point. We can continue to inject you for temporizing pain relief. We can do combinations of glenohumeral or subacromial injections. May or may not work for a significant amount of time. I'm sure they've already at this point failed plenty of PT, and if I were to suggest that to them, they just laugh in my face.
Yeah.
Or this is our next definitive step. And so again, we're reversing that anatomy. We're changing the center of rotation so that you do not need to have this intact functioning rotator cuff to move your arm anymore. So the goal of this procedure is to restore your function, because maybe you can't lift your arm above 30, 45 degrees, and pain relief too.
Yeah.
And so we're going to try to fix those things. And then the next thing they typically want to know is, like, what is my rehab course going to be? Because they may have already gone through rotator cuff surgery and it's terrible.
Also used all their insurance.
But like just the experience from like a pain standpoint and a recovery standpoint, it's so much.
Yeah.
And they don't want to have to go through that again. Yeah, that's not the case for these. It's one of my favorite surgeries that we do because people get better very quickly. Like,
especially after having most of them go down the long road of, it's been bothering me for so long.
Yeah. I mean, when I see people the next day, most of the time they have very minimal pain. 1 to 2 week post-op appointments, feeling great. Maybe they take pain meds for a couple of days. We usually start range of motion around 3 weeks and get them in therapy. They're only in the sling for 3 weeks. When people come back for their second post-op appointment and they're raising their arm overhead without pain and like sleeping through the night and having no problems and super happy, it's like the greatest thing ever. It's my favorite surgery.
Okay, not to bring you down off of your high, but what can happen? Like what bad things can happen?
Complications. Hello. I was just knocking on our fake wood table.
That's right.
Yeah. So complication wise, like right with any total joint infection is like the biggest one that you worry about. Dislocations, acromion fractures are the biggest thing. We were actually talking about this today that I had a PA student with me and he's going to be working with a guy that does a lot of shoulder replacements. And so we were talking about acromion fractures, someone who comes in and they've been doing really, really well in their therapy for the first month or two. And then all of a sudden they're like, yeah, I just started, and now I'm having all this pain and I was doing so great after surgery and now it just really hurts. That's my first thought is an acromion fracture.
Yeah.
And again, you're increasing the tension on that deltoid muscle. So it's putting increased strain on the acromion. And that can lead to acromial stress fractures. Fortunately, we have not had one again that was needing to be fixed. Typically they're non-displaced and we can just manage them by making them go back in a sling for a period of time and just shutting things down and slowing them down a little bit. So acromial stress fractures, periprosthetic fractures, infection, dislocation events.
So let's kind of head for head compare the two, just not like which one we like better because
I have my preferences.
I have my preference.
Yeah.
But, okay. So the goal, just to summarize, the goal of a rotator cuff repair is to make it not torn, like to restore the anatomy, which will decrease the pain, which will restore the function.
Yeah.
So what is the goal of the reverse?
Yeah. Well, the goal of the reverse is to restore your function pretty much and
get the arm
restore
over your head.
Make you not be in pain, when option A has failed or isn't an option.
Okay. So rotator cuff repair, best for younger patients with repairable tissue, primary tears, not terribly retracted, no humeral head elevation.
Reverse, best for an older patient. Maybe they already have some underlying glenohumeral arthritis, humeral head elevation, chronic rotator cuff tears, fatty infiltration of the cuff tendon, significant retraction, better reverse candidate.
Okay. The main muscle that we restore function with the rotator cuff repair is, wait for it, the rotator cuff, taking stress off of the deltoid and the upper trap. What about reverse?
So the deltoid is the important muscle
Yeah.
in a reverse. So you have to have a functioning deltoid
Yeah.
in order to do a reverse.
Yeah.
So that is an important thing to check for pre-op too, that they have good deltoid strength, intact deltoid function, axillary nerve function. Otherwise, you still won't move your arm after the reverse.
Yeah. Recovery longer with rotator cuff.
Yeah. By
Mostly.
far, people are like so scared of shoulder surgery after
Yeah.
their cuff because of what they've gone through.
Yeah.
The trauma.
Yeah.
Recovery pretty quick. Like I said, we sling them for 3 weeks. Therapy. Everybody is a little bit different on their rate of recovery for when they get their motion back. But I mean, a couple months.
Yeah.
I mean, I've seen people back at like their 3-4 week post-op visit and they have full range of motion
no, like,
already.
done.
And I'm
Thank
like,
you very
okay,
much.
I don't think you need therapy.
I know.
Let's go back when we can start some strengthening. But yeah.
Cool.
How long does a rotator cuff repair last? Loaded question.
Loaded question. So again, I think I looked up some statistics with this too. Survivorship. That's what it is.
So
Long-term survivorship is
94%.
94% at 5 years and 83% at 10 years. And again, that's one study.
Okay.
But if you want to talk about patient reported success, 94% of patients report improvement in pain, function, and overall satisfaction 1 year after rotator cuff repair. That's pretty good.
Yeah.
Okay.
Yeah.
But again, all the variables, like, are they a smoker? Are they a diabetic? Do they go back to overhead? So the biggest risk as far as like, will it last or will it not, is all those factors. The biggest risk is it might re-tear.
We could end up where we started.
We could. Yeah.
The survivability of the reverse in certain studies, 10 years, 90%. So it's pretty good.
Would you, side note, would you explant a reverse?
More commonly though, so when I'm thinking when he says explaining like an anatomic to transition to a reverse.
No, I meant like I normally will tell patients for the reverse, like this is the end of the road.
Yeah.
That's it.
Yeah. So, a reverse, we might also do that in a patient who has had an anatomic shoulder replacement for glenohumeral arthritis and then their cuff has failed.
Yeah.
So then you have to revert to a reverse. But yeah, I mean, I guess the only reason for doing that would be some sort of complication like I described above, infection, loosening.
Yeah.
Something is not, it's unstable, right? You need to change the size.
Have you ever seen a patient that we've sent you for a reverse and you send them back to us because you're like, no, go for the repair?
Mm-mm.
Oh, okay.
No. I mean, you guys typically, I feel like the captain is very, what's the word I'm looking for? He's willing to do it all. He's very aggressive.
He's repair your anatomical tissue in hopes that it will heal.
Yeah.
And again, the large tears that are retracted and the patient kind of looks like it's not going to heal.
Yeah.
I don't know how else to describe that, but we'll have that conversation. Like, the repair, the biggest risk for you is this may not work. And if the patient is like, no, I'm willing to do that, then we do that. But that same conversation, the patient will say, nope, just want it fixed. Don't want the risk,
Yeah.
So if it's repairable, we'll repair. And again, if it's repairable, that's open for interpretation, right?
Yeah.
But if it is fatty atrophy, humeral head elevation, like it looks like it's going to fail, we send them for a
Why
reverse.
bother?
And I don't like to do that, just so you know, because then we lose a repair. But if it's right for the patient, then it's right for me.
Yeah. But yeah, I feel like, I mean, you guys obviously do a good job at like picking out those patients that if you guys don't feel like it's a good one to fix, it's not a good one to fix.
Yeah.
Like,
yeah.
Yeah.
But I think it's really important also to just consider the patient's demands and their expectations, like with all things. Like I'll always end up back at this conversation. As long as you set the expectation of what this is and what it isn't, whether it's the repair or the reverse, I think you'll be in the right place. But you should never have a conversation for a run-of-the-mill rotator cuff where you're like, hey, you need a reverse. Like, there's an appropriate time and place to introduce the combo.
Yeah. Interestingly, though, just to touch on like setting expectations for it, we were talking to a doc on Wednesday who does a ton of reverses and asked him like what his basically
Criteria?
no, his threshold, like what he allows them to do post-operatively, like restriction wise. Typically I tell our patients like a 50-pound overhead restriction lifetime, because I feel like it's pretty heavy. Like what do you need to be lifting more than 50 pounds overhead if you're like 70 years old?
Like
and we just did a
dog food?
reverse, right? Like, I don't know, something like a stack of plates from the top shelf. I don't know. Christmas decorations from your attic.
Fair.
That's probably the extent of it. And he said he had somebody doing CrossFit and like doing overhead snatches with their. I was like, what?
That's
shocking.
That's shocking.
Truly shocking.
No, that's shocking.
And like competed in a CrossFit competition. If you're familiar with CrossFit, like, I mean, wow. Was my thought. I was like,
but I'm gonna go ahead and give him the benefit of the doubt that deltoid is probably pretty good.
Yeah.
Before and after.
Yeah.
That's crazy.
Yeah, it was crazy to me. So maybe I need to be less, I wouldn't say that I'm aggressive with it, because I feel like patient selection wise for us, like I've not encountered a patient who wants to be or should be doing CrossFit after their reverse.
No, that's probably not the patient demographic.
But yeah, like I guess don't have to be as cautious with certain things with it. So
take homes, right?
Yeah.
You've got to understand the rotator cuff and what is on paper, aka MRI or X-ray, or what you're seeing, diagnostic imaging, and then what the patient is in front of you. You have to put the two together. You can't treat the imaging. Cannot do it.
Yeah.
Because I have so many pleasant failed rotator cuff repairs.
Yeah.
That don't need a reverse because they're happy with their shoulder.
Right.
You know?
Yeah. If you can function, and I mean, like this goes with almost any orthopedic issue, right? I've got a couple patients right now that like proximal humerus fractures or a distal radius fracture. The x-rays look like shit. Like, I look at them and I'm like, oh my God, like I feel bad about this. Like, don't love it. And then I talk to them, they're doing great.
Yeah.
They've got full motion, full function,
How
or
is
at
this
least
possible?
to the degree that they need.
Yeah.
Right. Maybe it's not what would be appropriate for me, but they're like, well, all I need to do is sweep my house and crochet, and I'm not having any pain. I'm not going to sign that person up for surgery. Like, that's the worst thing I could do for them. Make you go through surgery if you're doing all of the things already that you want to and need to be doing, and
what are we gaining?
Living a pain-free life, like not appropriate for them.
Yeah.
So not treating an X-ray, not treating an MRI, figuring out what you need to do for that patient specifically.
Yeah.
So
wouldn't it be cool if we could get like a rep on here that would talk to us about
oh my gosh,
behind the scenes?
It would be really cool if there was a rep that like was present both for you guys' rotator cuff repairs, but also like was there when we did our reverses.
Yeah.
I mean, does that person exist?
I don't know.
I don't know
at all. I'd like to meet them.
Yeah.
I'd like them to come on our podcast.
If you know of anybody, reach out. So maybe we'll have that for you guys in the future at some point. We'll see.
Cool.
All right. Until next time.
Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.